Hey there, it's Carrie here from Wrap Your Head Around Silks. You're listening to the Expecting Aerialist podcast. How's it going today? So excited to have Dr. April Douglas on the pod today. Before we get started, there is that free gift in the show notes for you guys. Go ahead and click that link and you'll receive my ebook for free, Understanding Aerial Silks. It's meant to be a companion to your training. So go ahead and click that link and you'll get a free gift on July 1st. Since I've spoken to you on the podcast, we've had so many interesting stories and it's just blossomed, and I'm just so excited to bring you in here and there to kind of pull the strings together and give us some
I said zoom out a little.
Yeah, the zoom out. The zoom out is really good. And we've had a couple different conversations with some ladies about pelvic floor dysfunction. And I have had friends who have gone through prolapse recently.
Yeah.
And I had never known that there are different words for prolapse, if it's the bladder or if it's the rectum. I didn't know the specifics, and I would love for you to get into all the types, just all the types of dysfunction, because I feel like the regular woman doesn't know.
Yeah.
And what it ends up looking like and what it ends up feeling like and what that PT might be like afterwards. Incontinence, all the things. We've had more conversations about incontinence than prolapse.
Yeah.
But yeah, wherever you want to start, we want to hear it, because let's just get educated on this stuff.
Let's do it. Yeah. All right. Well, we'll start with prolapse. I feel like prolapse is something that either people know maybe too much about and it messes with their brain. Dr. Google gets in the way, or they don't know anything about it and they have no idea, what their symptoms even mean or whatever. So prolapse is really just laxity of the tissues within the pelvic floor. So if you want to imagine, you've got 3 tubes that are kind of layered on top of each other or all in a row. And you've got your urethra where pee comes out, your vaginal canal where babies and menstrual cycles and intercourse happens. And then you've got your rectum where poop comes out. And in between those tubes, you have fascia and skin. And that's kind of mostly, I guess the most simplistic way to describe it is there's laxity in between those tubes or with the ligaments that hold those objects up. And there's different grades. So if you Google prolapse, whenever I talk to my patients about prolapse, I'm like, do not Google it, because it's similar to an STD. If you Google it, it only shows you the scariest version. So it's always the one where it's falling out of you. And in all my years of practice, I have actually yet to see a grade 4 prolapse, which is the one where it's falling completely out of you. I've never seen that in the clinic. So that's usually more of a surgical candidate anyway. I've had one coworker who's had one, and as far as I know. So just not as common as the internet portrays. But what's really common is grade 1 and 2. So there's a little bit of movement of the tissues there when you test them internally. And so you can have the cystocele, and that's where the bladder kind of dips down a little bit. So if you think about
cystocele. Okay, this is the word that I was told. Yeah. Okay, cystocele, and then the other one's very similar. Rectocele, which makes sense.
Yeah, and then there's the uterine prolapse. And so the uterine one is where just the whole uterus is kind of coming down all at once. So that's probably where I think most of us would think is happening with most prolapses. But I would say majority are cystoceles or rectoceles. So either the rectum is kind of dipping down, and that one, the symptoms for prolapse across the board, it's usually kind of a heaviness is what patients report, especially after activity, end of day, running, that kind of stuff. At any time that there's more pressure through the pelvis. And so a lot of times end of day is a big one. But the rectocele symptoms, a lot of times you'll have maybe some constipation or like poop is right there and it just won't come out because there's that
Mm.
laxity. And so the rectum, again, very oversimplified way of talking about it, but it's kind of like kinked right there. And it's kind of stuck right there. So a lot of times, if you do what we call splinting, that helps a lot. So you wrap some toilet paper around your fingers and push on your perineum up towards the rectum, and poop just shoots right out. It's great.
You were talking about how the poop gets kinked in there with recticel. And if you push on the taint and kind of clear the way.
Think about the wall in between the rectum and the vaginal canal, or that fascia that's there. Then you can push on the perineum. You just wrap toilet paper around your fingers and you push upwards or towards the rectum. And then that helps support the wall. So then it can kind of help with that kind of kinked rectum or whatever. And then poop should just like slide right out. So it's really helpful for constipation when it just feels like it's right there at the entrance and it just won't
come out.
And then also with rectocele, it can be really helpful too. Where again, it's that sensation where it's like, come on, I know you want to come out.
Well, April, you're a pelvic floor specialist. Can you tell me the percentage of your day that you talk about poop?
Oh my gosh.
Like, is it at least 10%?
I would say it's probably anywhere from 30 to 50% of the day. And
it's awesome.
The best part is there's this thing called the Bristol stool scale. And it's a picture of all different types of poop. I highly recommend.
I've seen this. You showed it to me. Yeah.
Pretty much definitely all my new patients get to look at this chart and tell me what their poop looks like. So I get to ask like very awesome questions throughout the day.
I love that. And by the way, for all the podcast listeners, to let you know that my poop has gotten way better since I saw you.
Yay!
It's like what it's supposed to be. It's like what's the number on the scale? Like ideally?
Ideally is number 4.
Right. Like I was like at 6 or something. Now I'm at 4. I'm pretty proud of myself.
Heck yes!
I know. Oh, and I have this other pelvic floor story that I'm going to tell either when you're on the phone with me or before or after. And it's going to be great.
Oh, I am so excited.
Anybody could be listening to this. And now they know that about me. So, but we're talking about really, vulnerable things. And, we want to just have some levity.
I think it's just so important to chat about it. I've been a pelvic floor patient myself. It's not like I'm excited to be that patient either. I'm not excited to have an ankle injury, but it's important to chat about it. But if there's an ankle injury, I can talk about it at dinner time and not fear judgment. And I feel like it should be the same for pelvic floor. Yes,
normalize it. It's normalized on this podcast. That's for sure. Like me and the other April Moore-Skelton, we talked about the butthole for like a half an hour, like 2 weeks ago. It was great. I wanted to call the episode Butthole Diaries, but she's like, our SEO is just going to be off the charts, and that's not a good idea. I'm like, yeah, you're right. You're right.
The wrong crowd.
Yeah, we don't want the wrong crowd around here. So, okay. So I want you to explain all the different types of prolapse, but the questions popping in my mind are, number one, is this usually, for the most part, happening with vaginal deliveries? And why? Is it because the woman pushed too much, too long? Does it have nothing to do with that? And it's just the tension of the fascia with who it is and, DNA? What makes you have it or not after you've given birth to a baby?
There's multiple factors. You see it more commonly with vaginal births, but you still see it with C-section. A lot of people think C-section, you avoid all these pelvic floor dysfunctions, and maybe the stats are slightly less, but they're still there. But it's, carrying a baby. It is genetics is huge with just the laxity of tissues. So a lot of times people that have Ehlers-Danlos are far more at risk. or people that are a little loosey goosey, or a lot of people call them double jointed. They're not really double jointed, but whatever. So, probably in your world, there's going to be a lot more people at risk because they are naturally more flexible.
Okay. Are you talking about hypermobility regardless of how much they train their flexibility?
Correct. Yeah. So if there are people that are
Okay.
like, oh, since I was a kid, I can bendy everywhere, their tissues are probably genetically a little bit more lax, more hypermobile.
Okay.
And so they're typically more at risk for prolapse, but not necessarily. But, that it's a risk factor with genetics. But vaginal deliveries, also chronic constipation is a huge one because that is bearing down and pushing for a lifetime. And especially as a young adult or a kid, you don't know any better. So you're just
Mm-hmm.
pushing all day long. And sometimes full on adults are doing the same thing, but hopefully not after they listen to this. Um, so, yeah, it's lots of risk factors, but I would say vaginal birth, chronic constipation, and then also genetics are probably your top three reasons for being more prone to prolapse. So,
And so, but you've got a couple contrasting things because in my population, there's a lot of like flexibility training happening,
mhm.
but then there's a lot of super tight pelvic floors because of the strength training.
Yeah. So,
How do you think like the too tight pelvic floor goes with prolapse?
sometimes you see, so think high tension or gripping versus
Okay.
too tight. Um, because you can have a lot of laxity within the tissues, but then a lot of tone or tension within the muscles. So think like a really lax shoulder, a hypermobile shoulder. A lot of times the upper traps are gripping the whole time. So so with
Okay.
pelvic floors, it's similar, where the muscle can be high tension or tone, and it could be a protective response because of the prolapse or because of incontinence or just how their training is, but then also still have that prolapse or laxity.
Oh my God. I literally just had this conversation with my daughter because we were talking about the pee and then the butthole and what comes out both. Like we had this conversation, except just a little bit more advanced. So tell us about the pee.
So the cystocele, think about the space between the vaginal canal and the urethra, and that's a little bit more lax. Or the bladder, the ligaments that hold that up can be a little bit lax. So the bladder is going to kind of come downwards a little bit with valsalva or pushing or whatever. Um, and the symptoms that come with that can be nothing. I mean, all of them can be no symptoms whatsoever. But heaviness is the general one. And then sometimes it can create incontinence because if you think about the angle of the urethra, it can change it. So sometimes it can be incontinence, and sometimes it like kinks the hose in the opposite way, where like they don't empty their bladder. So it can kind of both
Mm.
ways, all kind of funky setups. But in the clinic, you test it. So oftentimes at your OBGYN, there are some amazing places that are testing it, but usually with a speculum, you're kind of bypassing all of those tissues.
What's a speculum?
The little duck bill thing for your exam. So if they use that, a lot of times you can't appropriately test it. So you have to test for prolapse. Usually they start in on your back when you're in that position in the stirrups. And in pelvic floor PT, we don't use stirrups or speculums. So it's still usually you start on your back, but especially if people are complaining of that heaviness and you want to do a real life legit test, then you want to test them in standing. So I'm not going to lie, it's a little awkward standing, getting tested for your vaginal canal and laxity. But it's the most effective way to see what's actually happening in real life. So when you're like walking around and squatting and
How can you be specific? Like, how do you measure that?
so there's an actual, so especially with urologists, they have a little, I don't even know what it's called, but it looks like a little measuring tape that they they will grade your prolapse. So with physical therapy, we're not allowed to diagnose. So a lot of times we're talking about like, well, it looks like you possibly have, it's most likely a grade, this. So we talk a little bit wishy-washy. How you test it is it's usually intravaginal. And so one digit is in the vaginal canal. And then you ask the patient to bear down or do a Valsalva maneuver. So Valsalva is kind of like you hold your breath and kind of like you're pushing out a baby or poop, even though you shouldn't actually push that way, but we do. And then you are feeling how much that tissue moves, if at all. And I would say most of my patients, the tissue moves at least a little bit.
Moves downwards?
Yeah, it moves downwards.
Okay. Okay, here's my question. If you had, okay, you haven't really seen a lot of grade 4, but if you had, a grade 2 or 3, is 3 common?
Yeah, I would say 1 and 2 is the most common. 1, obviously, super, super common because it's just a little bit of laxity, not a big deal. It's kind of like, it's just like if your knee bends backwards a little bit or your elbow bends backwards a little bit. Like it's not the end of the world. It's totally fine, but it should be, in my opinion, pointed out to you so you don't hang out like that. So you don't want to lock out your knees and have your knees bend backwards all the time. Or if you need to do that move, do it with a muscular control. Um, but you don't want to just like allow your knee to bend backwards and then prop weight on top of it.
Mm.
But hey, if you have chronic constipation, like let's work on that. If you are picking up your baby and awkward strollers and doing a Valsalva maneuver, so like that kind of noise all the time, like
Mm-hmm.
even when we get out of bed or out of a chair, a lot of times we like do almost like a pike and like, and so if you're
Mm-hmm.
doing a lot of those moves all day long, that's a lot of pressure down on the pelvic floor. And again, if you're just doing it every once in a while, not the end of the world, totally fine. But I think it's just important to be educated on it, especially when you're an athlete and you're doing lots of workouts, and also when you're a mom and you're picking up all this crazy heavy stuff all day long. So, and you are
Mm-hmm.
tired. So, a lot of times you're not thinking about things all the time. You're just trying to get it done. So, just other things to consider.
Dr. April, what does prolapse look like? I cannot imagine. I don't have prolapse myself. What does this look like actually? Do you look down there and you're like, something's wrong? Or like you can tell that you need to go see a doctor?
Most of the time, it's just symptoms that you feel but cannot see.
Okay.
It just feels like something's heavy or something is falling out but not falling out. Sometimes when you feel your own vulva, it feels like something's bulging.
Okay.
But then when you actually look, usually you can't see anything unless you're that grade 4. Sometimes with grade 3, that's when it's kind of at or beyond your hymenal ring. So, like the remnants of your hymen.
Mm-hmm. What do you mean? I still have that intact. Can you imagine?
Never know. You never know. But some people
Oh my
still have
God.
remnants, and you can actually
Mm.
feel like the hymenal ring. It's like a thickened tissue right there. But that's where they that helps grade the prolapse. That's what they're looking for is that hymenal ring. So sometimes you can see the rugae or like the little oh gosh, how would I describe it? Like the vaginal canal has ridges kind of within it, and so sometimes if you get a mirror out, you can see the rugae a little
Oh,
bit more, bridged skin there. So that's more for grade 3, where you can kind of just see it a little bit better. Um, but nothing is coming out at all. So,
okay.
but most
Okay.
of it's feel. A lot of times they just feel or it seems like. And then sometimes too, people, especially freshly postpartum, a lot of times people will say, "Oh, I feel that heaviness." But then when you go to test them, there actually isn't a prolapse concern, or it's so early on that I'm like, hey, there might be, but right now those tissues are still healing. So I'll still test it and check it out. But a lot of times I'm like, let's give it a little bit of time because right now, literally, your organs are repositioning themselves and shrinking, and it's not a fair time to necessarily assess. We still look, we still assess, but it's not for forever.
And when you're talking about those ridges and in the vaginal canal, you're talking, that's the uterus prolapse. But how about the other two?
That's for all of them.
Oh, it's for all of them.
Yeah, because all of it ends up affecting
The center.
mostly at the vaginal canal. Yes.
Okay. And then how does it affect women who are having, like, if you have like a grade 1 or 2 prolapse, can you have sex?
Oh, heck yeah. Honestly, intercourse usually helps because it's pushing those tissues back.
Oh.
Yeah.
I was like, whoa. I'm trying to think.
So,
Trying to think of what April's trying to tell me.
so sometimes people have discomfort because with the laxity of the tissues, sometimes you bump into the cervix. And so the cervix, if you can feel it on yourself internally, but it feels like kind of like a nose or a parrot beak kind of sort of tissue. But when you have intercourse, especially around menstrual cycle, the cervix sits a little lower. So also with prolapse, a lot of times the cervix may sit a little lower, especially with the uterine one. Um, and so if a object or penis runs into it, then it will feel like sometimes it's hitting a wall. So with
Okay.
prolapse, sometimes there can be discomfort with intercourse, but usually there's some workarounds. So if you like put a pillow underneath your pelvis,
It's like a positioning thing.
yeah. So a lot of times positioning can help a lot. And for some people, it totally gets rid of their symptoms. So for some, it can aggravate it. Some it
Interesting.
gets rid of it. So yeah, you got to experiment a little.
Okay, let me take it one step further. You're an aerialist and you just decide that you're just going to hang upside down a lot. Would that make any difference?
Heck yeah.
Yeah? I mean, just A plus B equals C in my brain, but I'm like, no, that can't be true.
That is great. So at the end of the day, for my prolapse patients, a lot of times, especially if they've been on their feet a lot, they're chasing a kiddo. I tell them to elevate their pelvis just like you'd elevate your ankle or your arm or whatever after an injury. And so you just prop up a bunch of pillows. So that essentially is trying to like basically make the vaginal canal kind of upside down a little bit.
Okay.
So that can help. Also, like at the end of workouts, a lot of times I tell people to end on an exercise that's kind of upside down. So, like bridges where you elevate your pelvis, that's one. So, with aerialists, it's even easier. Like, definitely just your end exercise, your end move is upside down. Sometimes I just recommend that for positioning. We don't know research wise if that's
Right.
super helpful, but we're doing the A plus B equals C kind of, common sense here.
Right.
And usually it helps out quite a bit. So, yeah.
Okay. And let me ask, is it about getting the tissues not so inflamed from like the blood flow, or is it about actually helping the muscles not stretch as much because you're not always gravity pulling one way?
Yeah, I think it's more of kind of, I feel like we think of it more of like a swelling management.
Okay.
There's not necessarily swelling, but that's kind of how we're thinking of it because compression usually helps. So a lot of times compression shorts, or even if it's a mild case of prolapse, I tell people like wear your yoga pants and hike those babies up. So give yourself a
Okay.
camel toe and go for it.
Yeah. That is the name of the podcast, Dr. April.
Get a camel toe and go for it.
I love it.
So yeah, the compression can be really helpful. There's some belts that kind of look like jock straps that can be helpful. So it's just providing some compression to that area that's helpful. So yeah.
And would you say for people, obviously, to go see a pelvic floor PT, but can they also just get these tools outside of seeing a doctor? Or what's your recommendation for prolapse if you think you have prolapse?
Obviously, I'm biased, but go see a pelvic floor PT and we can at least give you some guidance on like where are you at with the grades? Are you grade 0, 1, 2, 3, 4? Like where are you at? And then our job too is to refer you out when it's over our head. Or if we're like, hey, this isn't working, let's pull in someone else or a surgeon. So our job really is to pull in people if it's just if PT is not going to work. So PT is in my opinion kind of a great place to start because our name of the game is not to keep you in PT, it's to kick you out of PT in a loving way to graduate you. But
Mm-hmm.
we can kind of help you with that. Also, there is research to back up that with pelvic floor PT in regards to prolapse, we can confidently say that we can decrease your grade of prolapse by 1 grade,
Oh, that's
which
great.
is, yeah, which is awesome. So if you have a 3, we can probably get you to a 2, especially when it's freshly postpartum. I make no guarantees, but sometimes you can do a little bit better than that because you're dealing with, the body's just changing so much at once. But the hope is that that healing process can have better guidance with a pelvic floor PT. So you're making sure that you're doing the right breath pattern and the right type of exercises, and we're pushing you, but not shoving you. So there's lots of options, but I would start there. Also, remember, whatever profession you go to is what they'll recommend. So, if you see a surgeon, they're likely going to recommend surgery. If you see a PT, they're likely going to recommend PT. If you see a
Mm-hmm.
trainer, they're likely going to recommend training. So, um,
Mm-hmm.
keep that in mind on whoever you see. I think a lot of people go and see, especially surgeons, and expect them to come up with a holistic plan or something, and that's not their
Mm-hmm.
job. So, you
Yeah,
know,
and people believe in their jobs. Generally.
love that they would come up with a holistic plan, but that's also not their training. So you probably don't even want a holistic plan from that. So, but maybe there's a unicorn out there. I don't
We have all the types of prolapse.
know. Yeah.
We had a woman talk about incontinence on the pod
Yeah.
recently, and she had troubles with incontinence after when she gave birth, they had to use forceps
Mm-hmm.
because the baby wasn't coming out. Can you talk about, I guess, the different ways that you can end up with maybe incontinence or the other pelvic floor dysfunctions based on what happens during the birth?
Yeah. So mentioned it before, but with vaginal, typically there's a higher incident of pelvic floor dysfunction, but not by much. So there's that. For people who have had interventions with instruments, so forceps or a vacuum assist, they're more likely to have pelvic floor dysfunction. So I myself had a vacuum assist and also can attest that I had more complications. So nothing crazy, but so if you have instrument assist, that can affect pelvic floor a little bit more. Also, if you had a very long labor, and I'm talking stage 2 labor. So stage 1 is like water breaks, I'm having contractions. Stage 2 is when they say, okay, now you can push.
Mm-hmm. And then you're just pushing for a long time.
Yeah, if you're pushing for a long time or it was a quick exit. So there's some people that are like, in 3 minutes flat, the baby was here. So a lot of times the quicker deliveries and the slower deliveries, the pelvic floor, it's a series of muscles. It's either having the quickest stretch ever and it's not having enough time to like slowly warm up. So if you think about if you did a quick hamstring stretch, you might rip your hamstrings if you're not warmed up. Or if you have the longer pushing and that pelvic floor is just held on stretch for a really long period of time, sometimes that can affect the pelvic floor muscles, also the nerves. So again, think about your hamstrings. If you just hold it on a stretch, then it can likely impact your sciatic nerve or your hamstrings. There can be an overstretch issue. So they found that the pelvic floor, the levator ani muscles, oh gosh, I just looked it up. It was like 200 something or 300% that it stretches.
Oh, wow.
So it's kind of wild.
And I'm sorry, that muscle is like what muscle? Because I don't know that musculature very well.
So levator ani is the deepest layer of the pelvic floor. It's just what we imagine is the pelvic floor. There's more layers to it. It gets more complicated than that. But for the research, they focused on those muscles because they're going to give us the best data. But that was it. It was 200 something or 300% stretch. I forget what, but a crazy amount of stretch.
You know what was such a surprise to me when I went into labor? So my situation, I was like, I don't want to feel all this. So I got the epidural pretty fast.
Yeah.
But there wasn't very good communication. And the first bag got dripped down into me. And when they did the second bag, they didn't tell me, the anesthesiologist didn't tell me that I needed to give it to myself.
Uh,
That's odd, right? Is that odd to anybody else?
I never had that either.
So, long story short, I started having pain and I started to feel everything. And I didn't know because every time the nurse came in, I was just like, what should I be feeling? Pain or pressure? She's like, pressure. But because I have such a high pain tolerance, I was like, maybe this is what I should be feeling and it would be way worse.
Yeah.
I think what happened is I ended up just feeling everything. So,
Oh gosh.
yeah. And I was feeling the Pitocin and everything. I was feeling all of those things. But all that to get to my point, I thought my butthole was going to explode.
Oh no.
That's where the contraction pain, and I talked to a couple of different girlfriends, and that was the same thing. I thought it was going to be a pelvis, like really like strong cramping, but it just felt like my whole posterior pelvic floor was like expanding like a bubble. Have you ever heard this?
Yes.
Okay, what is that?
So a lot of times when there's a baby in the vaginal canal, the pelvic floor, especially levator ani, that deepest layer of pelvic floor, loops around the rectum. So if there's any stretch that's happening to the pelvic floor, it's also going to impact the rectum. Also, the baby is coming down the vaginal canal, which that vaginal canal just sits right on top of the rectum. So any sort of, that's also why poop is comes out often, because the baby's head or body is just pushing everything out.
Pushing it out like a tube of toothpaste.
Exactly. So that baby can just put a lot of stretch on that entire area. And again, that pelvic floor muscles, they are stretching an insane amount. And so it's gonna, all those tissues are all connected to the rectum. And a lot of times people cue in the delivery room to actually like pretend like you're pushing out poop,
Oh.
which pelvic floor PTs are a little bit more particular about the pushing cues, but honestly,
Whatever gets the job done.
whatever gets the baby out, I guess. But there could just be a lot of pressure and a lot of stretch to those tissues right around the butt. So,
Okay, now that we've got that cleared up, I I also have questions about this vacuum assist or forceps, which at least two of my friends either had done or kind of almost had to do. It's the one tool they have versus going into a C-section, correct? Like the baby isn't dropping down into the canal as much or is at a wrong angle and they use the vacuum assist to straighten that angle out.
yeah. So a lot of times as far as I know, the head is a little bit tweaked, or they just need a little bit more oomph. They need someone to push or pull a little bit, help it
Mm-hmm.
along. So the forceps, most of the time they don't recommend them anymore, but what do I know? I don't deliver babies. I had to have the vacuum assist. So they actually like put a suction, like a vacuum on the baby's head. And then with quite a bit of force, you push and at the same time they pull.
I mean, A plus B equals C makes sense, but as a physical therapist, do you feel like that is a better option for the long term of the mom and baby versus a C-section?
So when someone is doing a vaginal birth, or at least in stage 1, 2, especially stage 2, where they're pushing and then end up with a C-section, we call that a double birth, because then they've had all of the, I I don't want to say trauma, but it's really trauma of a vaginal birth. And then they have the trauma of a C-section birth. Have
Okay.
surgery and their pelvic floor muscles have been put on stretch and bared down and all that stuff. So a lot of times we call that a double birth, where it ends up in an emergency C-section or one of those. So I know from my experience, I had pushed for 3.5 hours, and that's kind of the cutoff around there.
Mm,
So they were like, all right, it's go time. We either need to do a C-section or a vacuum assist. And they allowed me the choice, which was nice.
mm-hmm.
I told them, like, I trust you. You guys are the experts. Like, what would you do? And the OBGYN said, oh, I'll do a vacuum assist. And I was like, oh man. And it's not like I wanted neither of them really, but I
Right,
was like,
right.
oh, the baby's going to be great. She'll be fine. Da, 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 da. And I was like, oh, I know the baby will be fine. What about my pelvic floor? And she just like started laughing. And I was like, she's like, I forgot your job. So she was like, let's just try one big push, and if it doesn't work, we'll go C-section. So sure enough, one big push, and baby was out. With my baby, she just had an extra huge head.
Mm.
Still does. She is 6 and wears a adult women's medium helmet. So lucky me.
Lots of brain cells. Lots of brain cells in that big brain.
So she just had an extra large head. So I think it just needed a little bit of extra help. So yeah, it's when you have instrument assisted, usually there's more likelihood of tearing and incontinence. And then also if there's different grades of tearing. So I always recommend to my pregnant patients, like, hey, ask what that grade tear was. Then we can kind of get a good idea of how far it went. But those with a grade 3, 4, where the tearing goes through the perineum and into the rectum.
Wow.
So 4 is all the way to the rectum, 3 is just to the anus. Those ones, they're more likely to have fecal incontinence, and not necessarily right away. It can happen later. Some people think incontinence is only right after the baby, but incontinence can happen in all phases of life. So I see people who have never had kids, have had kids, or menopausal. So it's not specific necessarily to the postpartum world, but
I can't even like listen to you because all I'm thinking is like sci-fi horror movie, woman's getting split in half completely all the way through. I'm like, oh my God.
yeah, I mean, the good news is
Oh,
majority of people are great, and our body is awesome and strong, and we heal from these things, and it's not that big of a deal. Also, if it does happen, you've got a whole team of people that are ready to rock and help you out. The unfortunate stories is when people don't know about pelvic floor PT or urology or the people that are all here to help you out. Or my main stink that I cannot stand is when moms just exchange war stories without help.
mm,
They're like, oh, yeah, then I had this. Oh, yeah, I do that too. I pee everywhere. Yeah, 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 that's normal. Or I poop my pants sometimes. Yeah, yeah, it's fine. You're like, no, 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 no. Like, exchange the war stories, but then offer the help or the referral, or let's go check something out, whatever. So there's just lots of people out there that can help, and if you are having issues, but large majority of people aren't having these issues, or if they do, they're mild and quick fixes, especially when you come in quickly. So it's easy.
oh my God. I learned so much every single time I talk to you. Okay, I'm gonna tell my pelvic floor story, and you can tell me what you think happened. I basically had explosive diarrhea in my first trimester, and I have IBS anyway. So what happens with me is during my pregnancy, I was constipated for the first time in my life, and then I was taking magnesium to try to soften it. But instead of something a little bit more mild, I ended up with a bunch of like, sorry guys, hard poo with a bunch of diarrhea coming
No.
behind it.
No.
And so, like, I'm on the toilet. I've only experienced this type of pain with diarrhea like twice in my life. And one was my first trimester, and one was like in my fourth trimester.
Yeah.
So anyway, so I'm on the toilet. I'm like getting all this out. I'm so glad I'm not farther along because I'd be so scared of like the baby getting hurt or whatever. Because I was a horror movie myself, Dr. April. And I was like pushing this harder poop out and I heard a pop, like an audible pop. I feel like that. Is it called an aponeurosis where where the glutes connect at that line of your anus? I think that I popped a fiber off of that connection.
Oh,
And I was sitting on a donut literally for the next 3
man.
weeks.
Oh my
I am not
gosh.
kidding you. I broke my ass, Dr. April.
This is a war story.
So I think that's what what happened. You listening to that with your professional opinion, is that what probably happened there? I even tell my doctor, I'm like, what is she going to do? What is she going to do about that?
So if you still have symptoms, that's when I'd be like, all right, let's.
No. I don't. Like, I literally had like a soreness. I think personal training brain that I have, I'm like, there's probably some scar tissue there now.
Yeah.
But then I don't feel anything. But yeah, I heard such a loud.
Yeah. I mean, if there's a loud pop, usually that's something ripping.
Yep.
Or snapping over something else. And usually with that situation, I would assume maybe something ripped a little bit. But
I think I tore something.
The hemorrhoid all the way to the old scar tissue, especially if there's IBS and we have gastrointestinal. So sometimes it can be a good thing when it rips the scar tissue. It's not comfortable, but yeah,
I will never know. I'm pretty sure I'll never know, but I have a good story. And if it was scar tissue, I'm just going to go with that. I'm going to go with like I ripped some of the scar tissue. It's totally better.
Happy ending.
Yeah. And it's so funny because Asa, my partner, he does all the audio mastering for this podcast.
Yeah.
And sometimes he like looks at me. He's like, are you serious? And I'm like, hey, it makes people feel seen out there.
Yeah. My husband is, mostly a good sport about everything. Maybe too good of a sport, but I think there are moments where he's like, do you really have to talk about that? Like, do you really need to go there? Like, do you need to talk about erections right now, April? Come on, I just met the guy. But, whatever.
No, I mean, yeah.
Part of my job. But it's
you're doing your job.
Clinical. It's not, gossipy, I guess. So.
And I believe that I'm doing mine.
Yeah.
Making women feel comfortable all over the world if they happen to do the same thing and just haven't told anybody yet.
Everybody poops. Everybody pees.
They should.
Yeah. And lots of people birth babies. So, whatever.
Yeah. And it just amazes me that like, now we've been talking about this for almost an hour and like women from the beginning of time have been doing this. Oh. Like how the hell? You know what I'm saying? Like there's just so much around it.
Oh, yeah.
It's amazing.
I could not imagine birthing my daughter. Well, first of all, I needed a vacuum assist. So I don't know.
If you were in a hut on bricks, upright, it would have been different.
Maybe it would have been better. Or maybe I would have died, like.
No, I mean, that happens so much. Yeah. That happens so much because we use technology so much
thank goodness for the options,
Dr. April, you're awesome. And I think that next time you come on this podcast, maybe we should talk about something like shoulder stabilization or something.
I'm in. Go more orthopedics. I can handle that.
I mean, we can talk about healthy shoulders.
Yeah, poop's going to creep in for sure. It's just going to happen.
Yeah. So it's great. I think this is an amazing note to end on this evening.
Yeah.
So thank you, Dr. April. People can find you on Instagram at mypt2go. And she is based in San Diego, but you can always do telehealth and she can always refer out if you need to find a physical therapist and a pelvic floor specialist wherever you might live in the world.
Yeah, always around and happy to answer questions as well. So,
yeah.
But thank you so much for having me. This was awesome. So fun to talk.
Oh my God. It's so fun every single time. So thank you so much, Dr. April.
Right. Well, lovely to speak with you.
Thank you so much to Dr. April for being here with us. Remember to check the show notes for that link if you'd like to receive my ebook for free. And thanks to Asa Watkins for post-production, and also a big happy Father's Day to my partner in crime. And thanks so much for listening. You've been listening to the Expecting Aerialist podcast.